Okay, we have finally made it to the place where most nurses want to start. The third principle, maintain a moist wound healing environment, otherwise known as what the heck do I put on this thing? First of all, is there infection? That is the first thing to address if there are signs and symptoms that make you think the wound is infected. And as time goes by, you have to carefully watch for signs and symptoms of infection. Erythema, induration, warmth, increased drainage, increased pain. It is also important to prevent infection. Not only is infection a bad complication for the patient, it also increases your cost of care. So make sure your patients learn about good nutrition for healing, maybe adding supplements like vitamin D, vitamin C, and zinc. Make sure they are well hydrated, and in some cases you might want to be proactive by using PHMB gauze and roll gauze. PHMB is polyhexamethylene biguanide, and I'm not going to say that again. PHMB is an antimicrobial that prevents bacteria from migrating through the gauze. It is just like regular gauze, so there's no learning curve, and while it does cost a little more than straight gauze, it is still in the gauze and tape price level, not the silver and outrageously expensive price level. If your patient is especially at risk for infection because of immunosuppression or diabetes, or if the home is not the cleanest, consider using a PHMB gauze product. And of course, if you are teaching family or other caregivers to do wound care, stress hand washing and clean technique, and make sure you set up a clean work environment area. The next step is to cleanse the wound. Usually just normal saline is the cleanser of choice. Wounds need to be well irrigated with it, preferably at a pressure of 4 to 15 psi, which can be achieved with a 19 gauge blunt needle and a 35 cc syringe. That is enough pressure to remove bacteria without damaging the tissue or driving the bacteria into the tissue. If there is slough or eschar that needs to be removed, um, you need to evaluate what will be the best in your situation. Slough and eschar harbors bacteria and they block the wound bed, and healing won't take place until it's removed. It can be removed by autolytic debridement, that is, letting the body debride it by adjusting the wound environment. You can do that by keeping the wound moist, but it is a slow method, and autolytic debridement won't work in the case of immunosuppression because the patient will lack the cells needed to break down and clean up the non-viable tissue. In home health, enzymatic debriding agents are often a good choice. Remember, when you use them, you should expect an increase in drainage as the non-viable tissue breaks down. Also, don't use them with silver dressings. Enzymes and silver inactivate each other. If there is infection and a lot of eschar or slough, it would probably be a good idea to talk to the doctor about treating the infection and having sharp debridement done. Manage exudate refers to managing the drainage so that it is contained, but the wound bed remains moist. Moist wound healing is the key to more rapid healing. If there's a large amount of drainage, alginate or foam dressings might be needed because they absorb the most moisture. Hydrocolloids hold a moderate amount of drainage while keeping the wound bed moist, but they are only appropriate for shallow wounds. If the wound is dry, you need to add moisture to promote moist wound healing, such as with a hydrogel foam from a tube or in a sheet. Also, a wound can be kept moist just by putting a transparent film dressing on it, but that needs to be checked frequently for excess fluid, which can cause peri-wound skin breakdown. In wounds with depth, it is necessary to eliminate the dead space. You can use alginate or a cavity foam. It depends on the wound and how much drainage there is. If the wound is dry, you can put hydrogel and gauze in the wound. You don't need to buy gauze with hydrogel already in it, but some people really like the ease of using those products. Controlling odor can be accomplished with charcoal dressings or by putting metronidazole, which is Flagyl, gel or crushed tablets into the wound. You would use a gel in a dry wound and crushed tablets in a wet wound. They kill bacteria that can cause odor in wounds. Also, debridement, good cleansing, and more frequent dressing changes help control odor. Protecting the wound can be done with the dressings used, but protecting the peri-wound skin is also important. This can be done with skin barriers, skin barrier liquid like skin prep wipes, ointments, or wafers like hydrocolloids. For people who have very delicate skin or who are allergic to tape, you can window a wound with hydrocolloid dressing and tape to that instead of to the skin. It is important to change dressings at appropriate intervals to prevent pooling of fluid on the surrounding skin. That can cause maceration and possibly more skin breakdown. So here's what I just said, only in a shorter form. If it's infected, treat it. If there's necrotic tissue, remove it. If it's too wet, absorb it. If it's dry, hydrate it. If there's a hole, fill it. If there's healthy tissue, protect it. So now I want to mention using categories instead of using actual product names. And this little grid here is another simple way to think about wound care. It addresses the shallow wounds and deep wounds, dry wounds and wet wounds, and you just look at your wound. Is it shallow and dry? Then use a transparent film or a hydrocolloid. If it's wet and deep, you could use an alginate. If it's really wet and deep, you can put an alginate in the wound and put a foam over the top of it. Anyway, I really like this little grid, and you might want to print it out. So now we're going to look at some wounds and what we would do about them. Here's a stage 1 pressure ulcer. Silly question. What caused this? Yes, we all know the answer to that one. It was caused by pressure. I think pressure ulcers are the best example of how important it is to remove the cause of the wound. In the case of this pressure ulcer, removing the cause, pressure, is the only treatment necessary. If you remove the pressure, this ulcer will heal. Okay, this is pretty gruesome. What caused this? It looks like this has several causes. First of all, there is fecal incontinence, probably diarrhea, which can cause skin breakdown in itself. But it looks like there's also a yeast infection. I'm guessing that the catheter was added after this skin breakdown occurred. Diarrhea plus urine causes a rapid skin breakdown and an excellent environment in which yeast grows. So we have to remove the urine, but we still have the irritation of the diarrhea and a yeast infection to deal with. Two causes have to be addressed. The infection has to be treated and the skin has to be protected from further damage so it can heal. Secondly, what are the existing or potential cofactors? Well, I can tell by the picture he's incontinent of both bowel and bladder, and he has mobility issues. I don't know why he's in this situation, but he could have had a stroke, he could have arthritis. Whatever the reason, he needs to be turned and cleaned up regularly because he can't do it himself. Then what will we do to maintain a physiologic, moist, local wound environment and heal the yeast infection? I'm going to share a little wound nurse secret here. It seems like it would be hard to heal, but here's something that can be done with a good possibility of success. You get nystatin powder, you sprinkle it on all that red weepy area, and then you get a good thick skin paste, a barrier paste, and put that right over the powdered area and all the rest of the area to protect it. The thing is, if you just put the barrier paste on there, you're creating a great environment for more yeast to grow. It would be warm and dark and moist, just the way they like it. And if you just use like an antifungal cream, you won't have the protection that you need to prevent further breakdown. So by sprinkling with powder, with an antifungal powder, and then putting the paste over it, it will heal. It will be protected and it will heal. You need to clean the paste off completely twice a day so that you can get the powder on the skin. But the rest of the time, just follow the manufacturer's directions as far as how much you need to remove. Usually you only have to remove enough so that there is clean paste left, and add to it each time that the patient is cleaned up. Next we have a diabetic foot ulcer. What was the cause of this? Was it diabetes? Well, yes, but how did that probably work? Diabetes caused neuropathy, which caused this patient to lose feeling in his foot. Because there was no feeling in the foot, this patient didn't know that something was putting pressure on his foot and a sore was forming. The pressure could have been from a shoe or something in the shoe, or it could have just been his own metatarsal head pressing the tissue between the bone and the shoe. Motor neuropathy causes muscle changes that result in more prominent met heads in diabetics. To reduce existing cofactors, diabetics need to keep blood sugars under control, stay well hydrated, and eat a healthy diet. As far as what to do for this wound, if infection is not an issue, the most important thing to do is to offload the ulcer. If the patient is up to it, PT can teach him how to be non-weight bearing using crutches or a walker, but often they need a special non-weight bearing boot, which requires a prescription. Whatever method is used, non-weight bearing means never putting weight on the foot, not even in the middle of the night when the patient gets up to go to the bathroom. Ask them that when they say they never walk on the foot, say, how about at night when you get up to go to the bathroom? You might be surprised at the answer. It is also necessary for the callus around the ulcer to be removed. That callus is another source of pressure. There can be further breakdown under the callus. Also, the standard of care for diabetic ulcers is that they are debrided weekly, so your patient might need a referral for that if his primary care physician isn't doing it. As far as the dressings, moist wound healing is what is needed here too. Add moisture if there isn't enough. Manage drainage with absorptive dressings if it is too wet. Change dressings as often as necessary. Now, what do you think about this foot? This is a very fragile foot. What caused these wounds? Lack of circulation. As nurses, we can't fix this. This needs surgery for reperfusion, and I don't know about you, but I missed that class. When looking at comorbidities, if the patient is in bed a lot, their feet need to be well protected all the time. They need to be well hydrated to enhance whatever perfusion they still have. They should not have their heels on the bed or any bedding on their toes, not even a sheet. Use a foot cradle. In home health, you can make a foot cradle with a cardboard box by removing one side of the box, and putting the box over the feet so that nothing is touching, and putting the bedding over the box. The feet also need to be kept warm with socks, but there shouldn't be any tightness at the tops of the socks. Cut them if you need to. As far as those scabs, and this applies to black heels also, I wouldn't do anything with them as long as they are intact and dry. The body has supplied its own protection from infection, its own physiologic moist wound environment. They need to be carefully looked at every day for signs of infection, but otherwise, protect the feet and leave them alone. Okay, now I just have a few little Oasis tips for you. I guess I might have, yeah. First of all, do not cause a suspected deep tissue injury a stage 1. If it is purple or maroon, it is a suspected deep tissue injury. Pressure ulcers are pink or red, not purple. This is vitally important because what if you call the suspected deep tissue injury a stage 1 and you go back next week and it's a stage 3? You just have to get this right. Okay, blisters, blood-filled blisters, are also suspected deep tissue injuries. Serum-filled blisters in a pressure area are stage 2s. And what are all stage 2s in M320 status of the most problematic pressure ulcer? They are number 3, not healing. It is the only choice. If it is newly epithelialized, it is considered healed and is no longer addressed. It's off the radar screen. Stage 2s don't heal by granulation, so the only other choice is not healing. It's either, not healing is the only choice. M1334, status of the most problematic observable stasis ulcer, is another place that makes me scratch my head. The response 0, newly epithelialized, is never to be used. If it is newly epithelialized, it is considered healed and it's not counted anymore. M1342, status of the most problematic observable surgical wound. You probably already know this, but just in case, for a surgical wound healing by primary intention, there are only 2 possible answers, and you might not like either one of them. 0, newly epithelialized, or it is not healing. What if it has a scab? What if it's doing great, but it has a scab? Well, you have to look at that scab. Does that scab mean that there is an open area under there? Is there a little spot where it is not healing by primary intention? Then you can address it as a wound, as a surgical wound healing by secondary intention. Most scabs aren't like that, though, and so they are still tricky. If they're very adherent, then it is not newly epithelialized, and even though it looks beautiful, there are no signs of infection, it's healing the way it's supposed to, your only other choice is not healing because they don't heal by granulation. Okay, that's the end of this one.